Okay, welcome back to the session. We had a rich discussion in the earlier discussion portion, but now we have a dedicated 45 minutes to hear from those in the room and those who are joining us on webcast. So to make sure that we get all of the questions from folks who are in the room or on the webcast, we are launching our Poll Everywhere, which is a real-time audience engagement tool. So if you've used Poll Everywhere, raise your hand. Excellent. Okay, so I'm going to walk us through the steps quickly. There are two ways to join, but either way, you should probably connect to the Wi-Fi. So please select the visitor Wi-Fi. There is no password. If you're having trouble, raise your hand and someone from the staff will come assist you. So if you are joining by phone, text C-Wellbeing 606 to the number 22333. If you are joining by computer using your web browser, go to pollev.com/C-Wellbeing 606. All right, so I'll give us a quick minute to do this. Okay, so far so good? Excellent. Okay, so if you successfully joined via text, you would have received a message back that says you've joined the clinician well-being session. So we're going to move on to the next slide for the sake of time. We're going to do a quick test. Okay, we just had So it's the instructions are still at the top of the slide if you need them. We just had Thanksgiving here in the States, so our test question is, the best Thanksgiving side dish is? Okay, we've got mashed potatoes with lots and lots of gravy, green bean casserole, dressing, not stuffing, mashed potatoes, green bean casserole, turkey, which may be a side, cranberry sauce, Brussels sprouts, sweet potatoes, squash. Sharon's getting hungry, so am I. Okay. Has anybody not, we got some jokes in the back. Has anybody not connected? Anybody need help? Okay. All right, so it looks like everybody is joining Poll Everywhere. So for now, we will pivot to questions that we received from our participants online. And then we'll be happy to take questions from those in the room. If you do not want to speak your question, please use the index card that we provided when you registered. Slip it to me discreetly somehow, and we will have a rich discussion. Okay, so the first question from our online participants is, the kinds of changes suggested by the report will require substantial investment by organizations at the same time that academic health centers and rural hospitals are struggling in managing costs. Although the interventions promise return on investment and value on investment, these returns are likely not to fall immediately to the bottom line. Have the study committee thought this through? Where will the resources come from to create this kind of systemic change? Anyone who would like to take the question?
It's a great question. I think that maybe before dealing with the specifics of this issue, I would maybe frame up the broader conversation of that sentiment applies to everything that we've done in medicine for the last 30 years. And if we believed that that was going to be an immutable force that we could not overcome, we would not have the quality movement that we've had in the United States the last 20 years. We would not have had any of our efforts around patient experience. And I think any of our major efforts to think about changing the dynamics of the learning environment that have occurred in changing some structure to graduate medical training and the like. So I think we should recognize that it is a powerful force, but that we've successfully advanced important initiatives in light of that in recent years. I think as it pertains specifically to the well-being efforts, it's a bit of a philosophical question, but I think it again relates to the notion of, is quality improvement a necessary cost center, or is it a strategic priority essential to the health of an effective medical center in 2019? And I think that organizations are all over the map on that same question of where is organizational well-being. Do we have to pay attention to it now because the National Academy is talking about it? AAMC, ACGME, other groups are talking about it. Some people are acting. There are at least 20 chief wellness officers appointed over the last 18 months. Major investments by many vanguard organizations. So now we have to keep up with the Joneses, and that's the motivation. And I think there are many that are at that place, but there are others that I think have gone to a very different place, which is recognizing that this is essential for everything we do as an organization. I think it comes back to that notion of, do you really believe the quadruple aim, or is that a nice thing to say? And I think the organizations that have bought into the notion that truly having an engaged, fulfilled workforce that is well and that is not burned out and that has high coordination and teamwork and collaboration is essential for all that we aspire to be as an organization with respect to quality, patient satisfaction, access, productivity. I think the comment spoke to the notion that there is a business case around this. A number of us on the panel have reported on that, objectively looking at different metrics around turnover, quality, patient satisfaction, reduced clinical work effort, and the like. But I think, again, it would be a mistake for us as a wellness community to imply that that is the first and fundamental reason organizations should act, is only because of a financial and economic case. And again, drawing analogies from other industries, when Alcoa changed and said safety is everything, not safety as a means to profit. Safety is the fundamental priority of the organization, and that all of our decisions will be based on improving safety for our workers, and that we believe everything will flow downstream of that. They bet the organization on that, and they proved to win the game in that sense. There are many analogies of that over the years, quality at Toyota and the like. And so, I think there is an economic case, there is a business case, there's plenty of peer pressure from other organizations that I think is forcing organizations to act. But we have to also really examine this question of, do we really believe what we say when we suggest that this is part of the essential foundation of a high-quality healthcare system for the United States? And if we do believe that, this isn't an economic discussion. It's a much more fundamental discussion than that.
Thank you, Tate. Sharon?
So I would just like to add to that. Excuse me, George, I would just like to add to that if you look at the report, Tate is absolutely right there about some of the economic impact and about the values and the priorities should be really at the core of decision making on that. And there are many whats in the report that do carry a price tag or do have some financial implication. But I would say there's also a lot of how in the report that often do not have as high an expense to implementation. Just looking at the how of decision making, the how of leadership, the how of teamwork and interprofessional work. I mean, those are the kind of things that are foundational to get to a stronger business case for many of the whats.
So I will agree with all of those comments. I'll just say that we have a whole range of resources available in our healthcare system. As was pointed out earlier, it's a $3 trillion system. So there are resources. They're not evenly distributed, and they're not possessed by all parts of the organization. So our expectation is that those parts of the organization with the most resources should be a model for others who are capable, the resource-rich parts of the organization, which are largely our big academic medical centers, ought to be able, inspired by this report and by their own findings in their own organization, to say this is a high enough priority that we will devote resources to doing it, and we will be a model and an example to others. In very many parts of the healthcare system, a lot of the things that need to be done are not necessarily costing money. They are about philosophy, they are about culture, that are within the control of the organizational units within both our healthcare system and our educational system, and do not necessarily have financial implications. They have to do with what kind of an organization are we, who are we, what do we want to be, and how are we going to run this organization. So I think we need to think across the spectrum. Yes, some things may cost resources, and some parts of the organization have those resources. But many of the things that we're talking about do not necessarily cost resources. They have to do with philosophy and culture.
Thank you, George. Okay, Jay Kaplan.
Sure. Jay Kaplan from the American College of Emergency Physicians. So I full well understand the desire to focus more of the consensus group to focus on burnout, given that there's a lot more data on that, a lot more literature on that. I don't want to, however, forget the other aspect, which is promoting well-being and joy. And I often think, and have had this image in my mind for probably 25 years, of Eric LaSalle, Dr. Peter Benton in the show ER, when after doing his first appendectomy, where he actually got to do the procedure as a surgical resident, he walks out of the operating room, walks down the hall, and he made a move that has remained really emboldened in my mind, and the move was this one. And when I first saw that, I got really jealous because I had to ask myself how often at the end of my day, as I was walking out of my office, as I was walking out of the ER, did I have that feeling of, yes, that's why I went into medicine. Yes, that was a great day, rather than, yes, I'm out of here. And so while the consensus report has a lot to do with preventing burnout, I'm wondering what your thoughts are, and that may in fact be the first step, and I'm wondering what your thoughts are about how we can promote joy in practice, because I think we all recognize that this life is not a dress rehearsal. And I think we all recognize that the inherent nature of what we do in interacting with patients and empathizing with patients is that we are going to pick up the pain and the anxiety that they bring to us. And the real question is, how do we transform that? And then how do we, at the end of our day, have that fist pump? And I think if we could focus a little bit more on that as well as on preventing burnout, I'm just very interested in your thoughts about that.
So Charlie, can you pull the slide with our conceptual model and the list of WONC system factors, or it might not be possible?
Yes, it's coming.
Anyway, so if you remember the conceptual model, we talked about WONC system factors that influence clinician burnout and professional well-being. And so you see on that graphic that orange, blue shade is actually really important. The lack of balance between job demands and job resources is likely to produce clinician burnout. Well-balanced job demands and resources is very likely to enhance professional well-being. So we think about them as in many ways being related to the way the system is organized. And maybe if we can go to the next slide. As you go down that list of job demands and job resources, you can think about all of them if there were better balance, better provided, better embedded in the way care is provided, that it would not only reduce, mitigate, prevent burnout, but also very likely to enhance well-being. That concept of job demands and job resources is a concept that's really well known in the broad literature on work system design and occupational safety and health. And sometimes people talk about the two sides of the coin of burnout and engagement. We framed our conceptual model in terms of burnout and professional well-being. So I hope that you would get away by reading our report and thinking about that those are the factors that are really what needs to be addressed, and whether it's in the work environment or in the learning environment. And I'm wondering, yes, go ahead. I was wondering, I was actually wondering who else wanted to talk.
Well, at the risk of being too reductionistic, I wanted to remind us of the study charge to our committee, because the National Academy is very organized, and one of the reasons the committee reports are so well done, in part, is because of wonderful staff we have, but in part it's because we have very careful guidance from the organization and from the sponsors about what are the questions that the committee is supposed to answer. And the study charge was examine the evidence regarding the causes of clinician burnout and the consequences for clinicians and patients. And then everything. So that was our job description. And we did that. But we, as Pascal said on that diagram, we were very aware that that's a glass half empty issue, and we also want to look at the glass half full. And a lot of people are doing that in the joy of practice and other ways of thinking about clinician well-being. So, but I think I think everybody would agree that you have to deal with burnout if you're going to get to well-being. So perhaps it's a next step. Perhaps the Academy might want to take on that next step. There isn't as much data, I'll tell you that, and that maybe we need more work in that.
There we go. Burnout's a symptom of a dysfunctional system. And I think there's an opportunity to make an analogy to patient safety. We can't measure safety very well. We can only measure unsafety, right, when bad things happen. Burnout's kind of like that. But more importantly, for those of us who do a lot of safety work, we have moved from what's called System 1, Safety 1.0, whatever you want to call it, errors, and how the system has failed, to understanding how the system succeeds and then using that learning. And I think that's the answer to your question, is one of the interventions needs to be, let's go figure out the places that do it right, whatever the many variables there, and then how can we translate that to everywhere else. I think purpose, meaning, joy, and purpose in work is so fundamental to why clinicians go into the field that we have to emphasize that, and we have to study it more, and we have to figure out what is degrading that and what can we do to prevent it.
Maybe just one other minor comment, Jay. I think your story is of the ER episode is great, and I would suggest it also holds the answer, because the work is inherently meaningful. We need to get all the stuff that's impairing the physician, the nurse, the pharmacist, whatever the care professional may be, from having that ability to provide the best possible care to their patient, a meaningful relationship with their patient, and the intrinsic rewards that come from that. That's why we all are in this field. And I think what has happened is all of our system structure processes and so on have sometimes made it very hard for the healthcare professional to do that. And to the extent we remove some of those things, that other piece is just there. It's that I took great care of a patient today. I made a difference. I reassured them. So I think that's the one piece. And then we do have to recognize that even though that inherent meaning is there, this is emotionally burdensome work. And that even when we have that yes moment, there are other parts of the work that are a weight for healthcare professionals. And we need to create the right collegiality, communities, support networks, support resources to help them deal with that emotional part of a career in the healthcare professions.
Great. Thank you, Tate. I just want to remind folks to continue to submit questions via Poll Everywhere. I'm tracking them, and I'll elevate them in the room. For now, Daryl?
Wanda, you may want to weigh in on this question as somebody who works both in student affairs and as a psychiatrist. But when I think about all this work going forward, there's this web of interrelationships between burnout and what I think really got the attention of the nation and the profession on this topic, which is the short path from being burned out to being suicidal, depressed, abusing substances, and so on. In fact, I find myself wondering, I don't know if it wasn't headlines about physicians, if those headlines about physician suicide had not been there, would we have taken this on as a profession the way we have? So as you thought about that, I was struck, Chris, by the way, when you were making your introduction, you said, we focused on burnout appropriately, as you were asked, as a workplace condition, but we know there are these related problems. And did you have any discussion, or how do we ensure that we keep the balance between fixing the system that burns people out, but still giving the much needed attention to the mental disorders that often coexist?
Well, thank you for the question. I think in many of our discussions, we were attempting to sort of discriminate between mental health challenges that may already be in place with individuals versus issues that became more exacerbated because of the workplace. And in an individual, there's just the individual. And so I think what we attempted to say was you could not simply write off the fact that individuals may have some mental health concerns and decide that they were just individual concerns. That we had to be able to have a conversation about what the work environment actually created for an individual who's sitting in that. And so there was a slide in one of the earlier presentations that sort of talked about the fact that the burnout, the workplace burnout, was a real issue. And that one of the outcomes of that might be seen in mental health. So like often when we talk about issues that work with medical students, so a medical student comes in and someone says, okay, the medical student is experiencing anxiety and depression, and so it's very easy to sort of write that off as something that is sort of intrinsic just to the individual. It's a very different method to really kind of look at a system's impact and how did the system, the experience of the student actually impact that outcome. And so we had a lot of conversations about the fact that we had to talk about burnout at a much earlier stage than clinicians. So that was something that the study committee really added, which I was very appreciative of, that we began to talk about the learning environment. Because many of the issues that students are placed in when they feel like they're in a vice, when they feel like they're just under pressure, it begins to really exasperate other issues for them. So I don't think there's necessarily a clean line, but it would be unfair to write off the experiences the learning experience, the environment of learning, the level of competition, the fact that often the learners are feeling like they are pinched to perform. They sort of take into health professions training that level of competitiveness that happens when they were in a pre-professional training situation. And then you add to that the extra burden of what happens as you continue in training. You go from medical student to resident, and now you are having to produce again. So I think what we really tried to do was to say, yes, those are, individuals can have very real mental health diagnoses, but systemically, we needed to look at it from a broader perspective. And we shouldn't just be comfortable knowing that 45% of our students are experiencing burnout and deciding that is just a way of medical education, but rather to really begin to systemically be thoughtful about ways in which we can improve that climate.
Pooja?
Another thing that we discussed a lot during the committee time was this idea of the stigma against mental health in the medical community. So we did focus a lot of time on recommendation 5, talking about how to eliminate barriers to people admitting that they need help and receiving help. And so I think that that's going to be a big thing to work on in the future as well.
Thank you. George?
Yeah, I just wanted to make the point. I think there were two kind of important organizational decisions we made under this broad umbrella of burnout, well-being, and the importance of systems approach, that we did decide to separately deal with the learning environment. There was one time we had a discussion that learning environment and work environment were almost synonymous. Learning is work, work is learning, and that we would miss a very important target and a very important message if we didn't speak specifically to the learning environment and only subsumed it among the larger work environment. And the second was a decision, and I remember the day we made it, and there was a lot of discussion around the table. Should we pull out and make a separate goal, goal 5, the destigmatization and the getting help and support? At first, we saw that as something that would run across all of the other recommendations. And we made a decision as a committee that we didn't want that to be lost. We made that a separate goal 5, while still wanting to preserve, not wanting to confuse people, preserve this distinction that burnout broadly is not a psychiatric diagnosis, but that an important subset of it needs important professional help. We wanted to be sure that organizations and accrediting bodies were not acting counter to that, which we believe they are in many cases now. So those were two very important conceptual and organizational aspects that went into the report to address your concern, Daryl.
Thank you. Okay, we're going to go to Bev, and then Rich, and then questions from online. Thank you. We'll come back
Good morning.
to you.
It's still morning, yeah. My name is Beverly Malone, and I'm the CEO for the National League for Nursing. And I am amazed at the work that you've done. I am so taken by it, taken by it. And the piece that I want to address first is about the card with woven and the definition that was up there. It brought to my mind, and I'm a psychiatric mental health nurse and a clinical psychologist, and so it brought to my mind the whole idea of Frozen, that amazing, you've all been to the movies or you've had to go, and that when the threads stop shimmering, it says the shimmering threads, that's when desperation, lack of choice, burnout set in, when those shimmering threads. So I just think that this piece here for me represents joy. I mean, I've got those intricate layers. I've got the spirit. I've got the belief. to me, that's your joy. And so I'm so happy you put it there. The piece that feels missing for me, and it's probably because I like it to be very out front, very direct, is how you integrate diversity into all of these wonderful proposals that you're making. Now, all of us who work in mental health know that stigma has something to do also with racism, and that racism has an institutional quality to it. And because you are doing the systemic work, the systems work, that some of those platforms that are built on racism. The way that it's done, it's not about. It's like an undergirding of the system. And so I'm asking you to talk to me a little bit about how you see not removing them, more acknowledging them and integrating it into trying to keep the joy, trying to keep the spirit of serving regardless of who you serve, trying to keep the essence of the provider that you have done so very, very well.
Well, let me take a stab at beginning and see if anybody else wants to address that. It may be that we weren't explicit enough about it, but in the section about addressing the system environment, there is a very strong section about culture. And embedded in that are all kinds of things. And I think, your point about systemic racism or historical ways of doing things or just, things that have to be met head on and have to be changed and that are perceived differently by different, and we talked about that earlier, the experience of that. I think of that as part of institutional culture, but as you point out, it's also part of societal culture. It's, if you look at our causal diagram, it's that even external to the external environment that we describe, there is this society we lived in. I think Linda Clever addressed that as a second-degree burn. That's another way of thinking about it. But that they're really being attentive to all those issues. And then I guess that, and this is a systems language, but having a non-punitive environment, a place where people feel safe in raising these issues, in asking for help, or in coming with ideas for change, that's a really important part of that cultural change.
Charlie, can you pull the Goal 1 recommendation, or can someone do that? Because I think your question is really fundamental to. I'm sorry. The guidelines. Getting all my slides confused here. The guidelines. The first part of the guidelines for implementing well-being systems includes a comment about values and the systems approach and leadership. Values is a key component of it, and so I think that's what I'm hearing you say. And there's not a lot here on that slide, but just as I think as a pointer to where I think those issues of values of diversity, of respect, of compassion, humanism, the common good. I think those need to be part of our conversation. They have to be part of our conversation. This is what we come back to. You've heard a lot about trade-offs. Where do we put our money? Where do we put our efforts? Those decisions are driven by values. And so how can we make sure that those things come up and are being clear, transparent, discussed, agreed upon? And so I think it's part of that process that we are encouraging everybody to get into.
Could I just answer a little
Sure.
bit? I think your values, and I think, Chris, what you said, all is important. It's just for me that if things are not put out in front, people tend to walk over it. They tend to forget it. And so it is not without understanding the power of what you've done. I appreciate it. But I do have acknowledged that, folks, if it's not in your face, it's like it didn't exist. That there's so much that will be pretended that as if it didn't occur, as if you didn't mention it, as if you didn't think about it. So that's all I want to say, because I know you had to get to where you are, this room may know, but there's a world out there that may not know.
Thank you.
I think that those are really great comments, and it's an important point to bring up. One of the things that we do highlight in the book is that this is really going to take a community. So this isn't going to work if we just appoint a chief wellness officer, right, who sits somewhere isolated from everybody else trying to work on these really complex issues. This is going to work if everybody at the table gets together, which means that that individual who is leading efforts within an organization to, whether you call it improving vitality, improving well-being, adding joy in medicine, reducing burnout, however you want to frame it, right? But that person needs to be at the table with whoever is leading diversity efforts, with whomever is leading safety and quality efforts, whoever is leading practice innovation and how we're going to use AI and machine learning to answer all of the world's questions, right? I mean, all those people need to be at the table working together with representatives from what we consider the other shields. So with education, for example, it's going to take a great partnership, and everybody has a responsibility to play. And I think that this conversation is really important around thinking about, who are those really important members who have been working on the climate, who've been working on the culture, who've been working on the systems that we need to bring into this conversation to have meaningful change.
Thank you. Rich?
Yeah. Additional comment. So as we think about how we move from today to next steps, which we'll be talking about this afternoon, I think that those comments are very well taken. I think Dr. Mitchell's comments earlier as well. I mean, we live in this context of the systems in which we live. And so there is more discussion about diversity, equity, and inclusion in 2019 than there was even 5 years ago. And so I think we had our discussions looking at what was in the literature, because that was the charge to the study committee. And Tate and Lottie sort of spoke to that earlier about what was in the literature. But obviously, there's not lots of discussion in the literature about what does it mean to be well if you come from a diverse background. And a part of that is this sort of societal place that we sit, where we have been so uncomfortable having those conversations that we operate as if everyone who steps into this door stepped in from the same place. So the fact that we can have those discussions today, and the fact that this afternoon, as we begin to identify the organizations and the community leaders that we want to interact in, I hope we'll just kind of carry that theme to the next step. Because we really did discuss it from the standpoint of what was in the literature. And I think the report shows you that. There's hardly anything. And so that within itself sort of underscores one of the challenges that we continue to have.
Great. Rich?
Yeah, Rick Summers from the American Psychiatric Association. Thanks for the opportunity to be part of this conversation. I'm a little worried that we may have a public relations challenge that we need to look at to really make this wonderful report, to really optimize its implementation. I'm worried that America sees doctors and healthcare workers as a relatively privileged group. We have jobs, we have, our problems, how do they compare with all the terrible problems that we're dealing with as a society? And that will limit the resources that will be deployed for this problem at a sort of broader national level and maybe even within our communities. And I guess I'm wondering, I'm sure I'm not the first person to have this thought, and that there's been plenty of conversation about that, wondering what people's thoughts are and how we can address that.
Start. Oh, thank you. That's a really important observation. You're right. It's not the first time we've heard that. We all are aware of it, and we need to be very thoughtful and appropriately humble within our communities about the struggles that people are going through who don't have a steady job and who are holding down 3 jobs or, are facing all kinds of challenges that even the most burnt out and beleaguered medical student or health professional doesn't have that. That's one of the reasons why we led off the title of our report with the focus on patient well-being, to improve patient care by addressing this challenge. And it's not just a matter of language. It was important to put that first. But I do think as we make the case for the importance of this issue, we can do it in two ways. And I welcome thoughts from others on this. And this definitely will be part, I think, of the collaborative thinking in terms of how we talk about it publicly and get public attention to it. Daryl's point about the suicide rates really do capture people's attention. I mean, that, you know, a human being is a human being, and when they die, it's particularly in suicide, it's a tragedy. And so I don't think people are saying, well, he was a rich doctor. I mean, you don't get that reaction. So I think looking at that ultimately, even though we do in our report make that distinction about not being a psychiatric diagnosis, we do want to begin to figure out ways of addressing that. The other is to address the effects on patient care and the effects on the system. And the third, and the just waste of human potential within this whole very expensive industry. And then the last is, and we haven't perhaps done enough about this, is solidarity with people in other workplace situations where there's a lot of stress. And we talked briefly about that in the prior panel. But I think we might want to think about some more reaching out to some of those environments as well.
And I would add to that, I don't believe that from an occupational health perspective that we would walk away from something that we knew was damaging to an employee. And so if we truly believe that burnout and lack of well-being is a workplace condition, that I think it deserves equal billing, somewhat of what Chris just said. I think the other thing is some recognition that most clinicians go into their work because it gives them meaning, purpose, we saw a lot of literature about the importance of being called into healthcare work as a calling. And so I think that those kind of characteristics make healthcare workers effective when not only do they address the more tactical issues, but they also address emotional and connectivity issues with individuals. And, perhaps it's a combination of that does create the workplace condition that promotes or creates a situation of burnout. And so, I think that yes, we could be perceived as privileged. However, I think that it's important to recognize that because of that privilege and because of the role that these individuals take, it fills a pretty important gap in healing and wellness of our society. And to me, that is some maybe rationalization, but I think some pretty important justification for us to take it very seriously as we would any other workplace issue.
Taking nothing away from those arguments, I think that this situation requires us to invest in ourselves. And I appreciate all of the organizations on the slide this morning that have basically funded this report. But I'm here to tell you that was the hors d'oeuvre, and that all these organizations need to put up and invest in our workforce and ourselves to really solve this problem. Now, I'll make two other points. One, the literature, which is what we had to focus on, primarily focuses on physicians and then nurses. But the point someone made earlier, I'm sorry, I forgot who, about our ancillary care providers is so important, and I think that we need to study that a whole lot more and then do something about it. Sterile processors, if anybody works in a hospital, probably have this problem. You can't hire them, you can't keep them. It's a terrible job, they're burned out, and as a result, not just inefficiencies, but patients are being harmed from inadequately processed sterile equipment. And there are lots of other examples of that, of people who are not advantaged. The last thing I'll mention is I think going to the government and saying we need new money for research in clinician burnout is the wrong approach. I think we as a profession in healthcare need to make some value decisions too. And maybe we don't have to invest quite so much in precision medicine, and instead, one example, and instead invest on things that actually have more of a direct effect on patients. I remember talking to a politician years ago, and he said, tell me about things that my constituents actually care about. Tell me about things that affect grandma. And it's a hard sell, I think, for grandma, how investing federal dollars in healthcare that we're going to genotype 1 million people, as opposed to we're going to address the well-being that is degraded in all healthcare providers, and so that the person you're interacting with when you come in with your problem actually will do a better job.
The Action Collaborative talked about this issue well before the consensus report, and we'll talk about it afterwards. And there are actually two flip sides to your question. One is looking at clinicians as privileged and losing empathy for them, but the other one is scaring patients. I could be going to a doctor or nurse or other clinician who's impaired in some way, and I'm not going to get good care. So there's two flip sides to it, and I think that George put it very nicely in his keynote address. We emphasize we're part of a team. We are interdependent. My well-being helps you, your well-being helps me. We work together, and by acknowledging the problem and being proactive, we will prevent future harm and optimize and enable better optimization of the healthcare system. And others may wish to comment on that.
Yeah, I agree with Matt. I think this is largely an internal initiative and needs to go on in that way. There was an interesting question earlier about the preponderance of evidence coming from medicine and very little from dentistry and pharmacy. And I thought about that a lot. And the big surprise, I think the question was, what was your big surprise? My big surprise was the extent of evidence that came out of medicine that I didn't know it was there. Now, why is that the case? Not quite sure. I think dentistry, as one of the ancillary professions, needs to really look at itself. And I agree with your question that it's going to largely be physician, or in this case, it's going to be dentist, fix it yourself. That's really where it's going to be. I'm not so sure I don't know medicine, the organizational side of it that well. I've learned a lot here, but I think in dentistry, it's going to really be our organizations that will have to be encouraged and motivated to look at this. We first of all need to look at the problem. Do we really have a problem in dentistry? I don't know. I'm not sure. I think we do, but I could be wrong. So there are going to be different levels of how we address this whole issue. It'll be very different in medicine, where there's already this incredible body of understanding and knowledge, and largely what you're seeing here today, whereas not so much in pharmacy and even less maybe in dentistry.
So your question's a good one, and I tried to address it in part. This is not about the job satisfaction of a highly privileged group, and that it is a societal issue. And it really gets to the question of who and what do we want to be as a society. And I think that we want to try to frame it that way. While I agree with the other comments, that most of this work and the funding of the work needs to come internally from within the healthcare system, and we shouldn't be asking the public to pay for the fix. But I do think we do need to make the case that the motivation to fix it is not a selfish motivation, just so we feel better, but it is about helping to make the society the kind of society we want to be. And with that comes an obligation, a kind of promise on our part that as we work together to fix this, we're actually going to be better citizens of this society too. That we have a responsibility to contribute to the national dialogue about how we can all be better, and how we can address other issues of access, inclusion, diversity, and even broader issues of non-humanitarian policy. So I see this as us needing to fix ourselves, but also framing it as a broader societal question of who we are and what we want to be as a society, and what all of our roles are collectively, and helping to bring us to that point of being the kind of society we want to be.
Okay, thank you, George. We've got one comment online, and then we'll close with Frank Opelka. What do you recommend for institutions as they embark on their journey to survey the climate and needs of its clinicians and learners, to identify the similarities and the specific nuances that compose that system and the specific work environment or culture? Any guidance for folks who are surveying at the institutional level?
So within the National Academy of Medicine Action Collaborative, there are a number of resources to help individuals take this journey of starting to think about how to measure, what tools to use, how to do it in a way that's pragmatic and practical outside of a research study. And one of the white papers is entitled Pragmatic Approach to Measuring Burnout. And it really sort of lays out what are the available tools, the pros and cons, the lengths, what do you need to think about in advance before you do this, and has a bit of a roadmap for you. In addition, within the Action Collaborative, there's also a toolkit that summarizes the available measures currently for measuring burnout, as well as other dimensions of well-being. So I would really direct individuals to those resources, and then importantly also to let us know, how those resources are working for them, and where may be some additional opportunities for us to provide information that could be helpful for organizations interested and willing to embark on this journey.
And just building on Lottie's thoughts, and I think the question, as someone who's done a lot of survey research, I would emphasize to the person asking this question, surveys don't provide answers. They provide data that helps you frame the right questions. And so to the extent we all need these assessments, your survey, no matter how robustly you design it, will not give you the answer to what you need to do as an organization to make progress. That is facilitated through the conversations you have with the people in your organization that are better informed and structured based on what you learned from your assessment tool. And again, this speaks to the notion that's strongly in the report about participatory decision making. And the frontline workers doing the work are the people who know what needs to change and what would actually make a difference. And so as part of your organizational assessment, you need to get down to those conversations at the local unit level to really be addressing the right things. And so again, I think bear that in mind, that your survey shouldn't be the answer of where we are and how we're going to act. It's the first step of a conversation.
And I might add one more thing for those organizations who have been engaged in some of the programs that began as nursing programs but now are proving to be successful beyond just the nursing discipline are programs around the healthy work environment by the American Association of Critical Care Nurses, as well as the Magnet program, which were all generated because in nursing we've studied burnout for over 3 decades, and it has been helpful to have those structures and processes in place to learn from them and actually understand how those things have impacted the burnout levels of the nursing part of the workforce, and to really identify ways to take those beyond nursing in order to impact the entire healthcare culture. So that'd be one other thing I would offer.
Sharon. Frank?
Frank Opelka, the American College of Surgeons, and I also want to congratulate you on an incredible body of work. I don't think we truly appreciate the depth and the breadth of this, and it's only going to reveal itself over time as we dig in deeper. And with that, I want to bring forth some of our own action, which was not action intended to deal with burnout. It was action intended to deal with better care. And yet, I think some of this fits in the burnout environment. And it takes the systems engineering approach. But I want to toss it out there to get your reaction to it. The College of Surgeons began over 100 years ago as a standard-setting body, and we set standards for bricks and mortar, that there were almost as many hospitals 100 years ago as we have today, but the care you got in one hospital to the next was highly variable. So we set standards, and then after 50 years, we gave birth to those standards as what you know today as the Joint Commission. We moved beyond that and started setting standards on care models. So we set standards for trauma, for cancer care, for bariatrics, and so forth. And so we did that for the last 70 years. But in the last 10 years, we've really recognized this whole issue since To Err is Human, that we've got a quality problem. And so we intensified the care model standards within clinical domains. And now we have roughly 14 to 15, with 4 or 5 more in the pipeline, care model standards that are around conditions: complex GI, vascular, pediatric surgery, frail and elderly surgical care, trauma standards, bariatric standards, breast standards. And institutions in the country are getting certified to meet these standards. And the domains look like the domains that are out there that you talked about. There's an administration domain, there's a data domain, there's a quality improvement, how do you use data to drive improvement domain. There's domains that deal with personnel. There's domains that look at resources. So when you look at that, take trauma, for example, there's 250 standards to be a trauma center. And when a congressman was injured on a ball field not too long ago, no one whipped out their phone and said, who's got the lowest readmission rate? They looked for who was the level 1 trauma, because it sets standards, and those standards actually mean something. And the team that's built around it carries a badge of pride that they achieved a certain set of standards that met these engineering elements. Yet much of what we have today in the way that we purchase and go after healthcare and the way that we brand our healthcare systems is not based on conditions and how we perform in conditions. It's still very much based on bricks and mortar. So my question to you is, as we go forward, I can wrap in these standards that are going to come from this body that are dealing with burnout. I can wrap that into our standards programs, and I'm actually thrilled and excited to do that because I think they're really cool and they're going to make a big difference and they're going to bring back the joy of practice. So I'm excited about what you're doing. But my question to you is, do we have these standards set on bricks and mortar? Do we have these standards set on conditions? Is it a mix? Is it a blend? It's part of the research function I still don't know the answer to. We are certifying places all across the country. We have a major payer that's doing this in one state with us, where we're going across the entire state doing these certifications. They're condition-based certifications. So as we think about this, as we think about the system engineering approach, which I truly like, I'm just wondering, where is this? How is this part of the research agenda, and what your thoughts are? Thank you. Again, thank you so much for the work you're doing.
To take a stab at it, I think the way an engineer would look at is as a process. And I was having a conversation with someone during break. The way an engineer thinks about a process is, a series of activities that come together, organized with different resources that produce an outcome. And that's the way we think about a process. And the system is there to support the process. So when you hear us talk about system, the system is just not something that's out there. The system has the main function of supporting that care process and the delivery of the care process. And what you may want to think about in your initiatives is think about that idea of the system and the process really coming together And looking at the process is really that patient journey. That patient, they may be a trauma patient one day. 2 weeks later, they go see their primary care physician, and now it's a different sub-process. But what's the connection between the two? And I'm sure that the primary care physician that sees that patient 2 weeks ago would love to know about what happened during that trauma care process and who did what and so on. That's important for decisions that they make with the patient regarding follow-up treatment and so on. So I think we really also need to think about that the system and the process come together and that they need to be designed together. And the process is about the patient. And so making sure that we take that perspective of the patient journey and understanding what things look like for patients as they transition from one care settings to the other. We cannot optimize one piece of the care process or the patient journey, whether it's the emergency room, the OR, the primary care clinic. We have to look at the connections between them. And I know that it's very challenging, but I think we need to also pay attention to those interfaces and interactions along that patient journey. Because if they're not well designed, that's going to create frustrations for all of you and going to create breakdowns for patient care.
So first, standards are very important to a system, but they aren't the only thing. And having worked at a number of trauma centers, I can tell you, notwithstanding certification, there's still tremendous variability, even in trauma care at those institutions, for lots of reasons, good reasons. You need leadership, you need culture, you need all the things that Pascal talked about. So it's really important, but we need to not rely solely on particularly externally mandated standards. The other point I want to make is when I have mentees who come to me and say, should I work on this project or this opportunity, I always say, never do anything if it can't count twice. And in the report is a section about the relationship between traditional occupational safety, patient safety, and clinician well-being. And the goals and often the structure and processes of those things can be very well aligned, or you can have an organization where they're actually working at cross purposes, not just by taking resources from each other, but actually implementing a safety or quality initiative that has adverse effects on clinician well-being. And so we need to be wise, and we need to have communication across all of the stakeholders, both within our organizations and externally, about how do we do this smartly.
Thank you all. Okay, we are a bit over time. Quickly get.
Sorry, one last point. I think the thing that is important to remember as well is that the face of medicine and where we're headed in medicine is rapidly changing. And so we need to be able to look at systemic changes and the culture of medicine and be able to translate it to the upcoming changes with AI and not just focus on traditional medicine.
Thank you, Pooja. Okay, apologies to those who had questions in the room or on Poll Everywhere or on the webcast. We are out of time, but we will have many opportunities to raise these questions throughout the day. For now, please join me in a round of applause for the committee.